clear understanding of the anatomy is the first step in appreciating our care of these patients post these procedures. So the anatomy of the knee is where we'd like to start. I guess if we classify the knee joint, we classify it as a hinged knee joint. A hinged knee joint in where it allows for what we call flexion and extension of the knee. So it moves through an axis where it allows flexion of the knee or bending of the knee and extension. However, it does provide a little bit of rotation as well, and this rotation is where the tibia, the shin bone, will either rotate medially or laterally in relation to the thigh bone or the femur, but we classify it generally as a hinge joint. The other interesting things to know about it, it's called a synovial joint. Synovial joint in the fact that it produces, the knee has synovial fluid within it. We call this kind of a lubricant within the knee. It's like the oil within your engine. The knee joint's kind of made an interesting joint because it's made up of two joints in effect. It's made up of a tibiofemoral joint, the tibiofemoral joint where there's an articulation between the tibia and the femur, tibiofemoral joint. And then there's also a patellofemoral joint, which is the articulation between the patella and the femur. Both these articulations are encapsulated in what we call a joint capsule. And the joint capsule is just connective tissue which just surrounds and encapsulates the joint. Within this joint capsule, on the inner lining of the joint capsule, has got the synovial membrane. So this synovial membrane which produces the synovial fluid. The synovial fluid is also very important in the fact that it has lots and lots of nutrients in it, lots of proteins and so forth, which help to keep the structures inside the knee joint, some of the ligaments and cartilage. It helps to keep those structures healthy. So another thing to consider is the tibiofemoral joint component of the knee joint is what we call the weight-bearing component of the joint, and we also, as I said, is the patellofemoral joint. The function of the patellofemoral joint, obviously we've got the patella, which is like a sesamoid bone which sits within your quadricep tendon, and the main function of this is really to help improve the mechanical advantage of your quadricep and generate more forces across the knee, specifically into extension, which is obviously very important for locomotion and motion and so forth. So we have to talk a little bit more about some of the structures inside the knee joint. The first cartilage we want to talk about are the meniscal cartilages. There are two. There's a lateral meniscal cartilage found on the lateral part of the knee, and there's a medial meniscal cartilages. The best way to describe these cartilages, they work as shock absorbers between the femur and the tibia. So obviously it's the weight-bearing component, so those structures sit like little wedges, helping to control or soften or dampen weight-bearing forces. These little meniscal cartilages are C-shaped in design. They have attachments to the tibia, so we talk about them being the posterior root, which is the attachment of the cartilage around the back, and the anterior root attached more towards the front of the tibia. The rest of the cartilage is fairly mobile and allows for general movement so that it can adjust itself to the movement of the knee, whether it's in extension or during the process of bending or flexion. The other cartilage group that I want to specifically talk about now is what we call the articulating cartilage or the hyaline cartilage. Now what is this? The articulating cartilage is the cartilage that we find specifically on the ends of our bones. This specialised surface cartilage, I sometimes refer it as laminate cartilage. This specific cartilage is about 3-4 millimetres thick. It lines the very end of the bone and it allows for the articulation of one bone to the other. This has a very specialised function as well in the fact that it protects the underlying bone. The way I often describe it to patients, it's a bit like the laminate on this tabletop here. It helps to protect the chipboard underneath. And this laminate cartilage, as I said, works slightly as a shock absorber, but most importantly is to protect the ends of these bones. This laminate cartilage can be traumatized as well. We can find that through the normal aging process, this laminate cartilage will slowly wear down, and as it becomes thinner and thinner, we might find that it starts to break away, to fray, become unstable. And again, certain procedures that we'll talk about in the arthroscopy of the knee can be used to try and clean up this surface cartilage when it wears. But probably the more significant thing to think about is that when we wear down that surface cartilage right down to the bone, that is what we classify as arthritis. When we start to reveal the underlying bone, which funnily enough has most of the nerve endings, and therefore once we wear down to this bone, this subchondral bone, we then start to generate more symptoms, which are classically pain and so forth associated with arthritis. We can also get trauma to that surface cartilage. So through certain activities, you can land and pivot, and you can take a divot out of this surface cartilage. We call this the chondral defect. Again, there are surgical procedures done that can be used to salvage this defect. Sometimes it may need to be removed, sometimes it can be reattached. But this surface cartilage is critical, as once we've worn it out, once it's actually worn itself back down to the bone, that's literally what we call arthritis. So it is a very specialised cartilage, and one that we can't sort of underestimate. Even though we talk a lot about the meniscal cartilages, the surface articulated cartilage is critical to the knee. Now these are the two important cartilages, the hyaline cartilage and the meniscus cartilages. If we talk about some of the ligaments around the knee, which are obviously, a ligament is a structure that runs between a bone and a bone. It helps to stabilise a joint, it helps to make sure that a joint moves in its correct movement pattern. So it helps to minimise unwanted movement patterns. We have many ligaments inside and around the knee, and we're going to talk about some of those now. And again, you'll see many procedures at St Vincent's Hospital Kew in which we repair these ligaments or reconstruct these ligaments. The first ligament we'll talk about is the medial collateral ligament. It's found on the medial side of the knee. It is a thickened component of the capsule. So we call it a capsular ligament because it's part of the joint capsule. We then have the lateral ligament, which is found on the lateral side of the knee, again attaching from the femur to the head of the fibula here. This is what we call an extracapsular ligament. It sits outside of the joint capsule itself. So it actually looks like a very distinctive band like this on the outside of the knee. So we also have intracapsular ligaments, and these intracapsular ligaments sit within the knee joint. And the two main ligaments that we're talking about here are the anterior cruciate ligament and the posterior cruciate ligament. The posterior cruciate ligament is a structure that sits a little bit more towards the inside the knee, a little bit towards the back. Its main role is to stop posterior movement of the tibia in relation to the femur. And that's part of the reason why we call it a posterior cruciate. The anterior cruciate runs anteriorly, and it stops anterior translation of the tibia in relation to the femur. And the other major role that the anterior cruciate has is it helps to check some of those rotational movements which we talked about at the start of the video when we were talking about the actions of the knee joint. Hence, when we have sports that involve a lot of twisting and turning and cutting, this ligament is critical in trying to stabilise the knee with twisting and turning activities. And this is part of the reason why when we damage the anterior cruciate ligament, we often get a lot of instability when we're dealing with these cutting and turning and twisting sports. A knee with no anterior cruciate ligament in many ways becomes an unstable knee, and for this reason we see a lot of anterior cruciate reconstructions. So we often refer to the anterior cruciate ligament and the posterior cruciate ligament as the ACL and the PCL. So these are the main ligaments that we find inside and outside the knee joint. So another anatomical structure we find around the knee joint are the bursa. A bursa is a fluid-filled sac that sits between anatomical structures. So we might find a bursa between a ligament and a bone, or a tendon and a bone, and these help to minimise friction between these surfaces. It's a bit like a fluid-filled sac or a balloon of water filled between my two hands. As I move my two hands, this fluid-filled sac helps to minimise the friction, helps to stop these structures rubbing on each other. And there are many bursa around the knee, but the ones that we'd like to talk about at the moment, there is the pre-patella bursa, which just sounds like it's pre in front of the patella, and again that helps to minimise the friction between the patella and the skin. There's a suprapatellar bursa. We often call it the suprapatellar pouch. It's an extension of the joint capsule, and we tend to find that this runs up above, just above the kneecap. We often see this post-surgery or post-trauma to the knee, where this sort of semi-horseshoe shape or thickening develops above the kneecap. This is a swelling of the suprapatellar bursa. As I said, it communicates with the knee joint, so often if the knee joint is traumatised or structures within the knee joint are traumatised, like the ACL, we have blood within the knee joint which irritates the synovial membrane, produces extra fluid, or there's blood within it, you'll see this swelling like a horseshoe shape above the patella. And this is an interesting thing to look at when examining a knee post-surgery, to have a look and see if this suprapatellar bursa is swollen and inflamed. There's the semimembranosus bursa, which sits around the back of the knee. We sometimes refer this as to a Baker's cyst when it becomes pathological. This Baker's cyst can communicate with the knee joint. And we see these Baker's cysts, and there's these cysts that we sometimes hear about, occur when there's trauma within the knee joint. So if the knee joint is irritated and swollen, we sometimes see this semimembranosus bursa or Baker's cyst become inflamed and irritated. And they're some of the more common bursa around, but I think there's something like 32 bursa found around the knee joint itself. These are the more common ones, and these are the ones that we sometimes see post-surgery.